Hello and welcome to the World Stroke Academy Paper of the Month interview. My name is Otávio Marques Pontes Neto. I am a neurologist and titular professor of neurology at Ribeirão Preto Medical School, University of São Paulo, and I currently serve as the editor-in-chief of the World Stroke Academy. And today is my great pleasure to welcome our guest, Professor Craig Anderson, Director of the Brain Health Program at the George Institute for Global Health and Professor of Neurology and Epidemiology at the Faculty of Medicine of University of New South Wales in Sydney. Professor Anderson is a globally recognized for his leadership in stroke research, particularly for the management of intracerebral hemorrhage. And today, we'll be discussing our recent publication, the publication led by Professor Anderson, which is a pool analysis of individual patient data of the INTERACT trials that was recently published at The Lancet, which provides important new insights into the timing and effectiveness of the early intervention for blood pressure lowering in ICH. Professor Anderson, thank you so much for being with us today and welcome.
Thank you very much, Octavio. Hello, everyone.
Yes, Craig, can you please tell us a little bit about what motivated you to conduct this individual patient data pool analysis, combine all four INTERACT trials?
Look, the whole purpose or benefit of pooling studies and meta-analysis is to get more precision of the treatment effect overall, but often more importantly in particular subgroups of patients by their characteristics or by, for example, in intracerebral hemorrhage, by the timing of therapy. Because in an overall individual trial, you never have the power to adequately assess treatment in subgroups. But if you can pool data across a number of studies with consistent methodology, you get more precision over the treatment effects by different characteristics.
Okay, great. Craig, can you then explain to our audience what were the main important findings of the study?
Well, what we did was we pooled all four INTERACT studies. And the benefits of this approach is that all of the studies had a consistent methodology, they had a consistent approach to the treatment, and in general, very broad inclusion criteria for the characteristics of patients. The advantage of including INTERACT 4, which was quite unique in being pre-hospital, allowed us to increase the number of patients who received blood pressure lowering within the first few hours after the onset of treatment. Whereas one could argue that a major limitation of all of the other INTERACT studies is that it took several hours before blood pressure was under control overall in the patients. So by putting all of this patients together with a consistent methodology, consistent treatment, we were able to get a very good number of patients in all of the various time parameters. And the motivation was really to understand how the benefits of blood pressure lowering related to the time from symptom onset. And we showed very clearly a linear relationship between the timing of blood pressure lowering and both clinical outcome, which we generally use as functional recovery, and hematoma growth. Now, hematoma growth is a little tricky, it's a little complicated because we use the two standard metrics for that, which is relative or absolute growth. And we showed a very nice relationship with relative proportional growth by time, but it was stable for absolute. So I think the way in which we measure hematoma growth very much is dependent on the baseline hematoma volume in terms of its clinical implications. But anyway, I think the value of this paper is showing very clearly a consistency in time is brain that we accept and understand for acute ischemic stroke also holds for intracerebral hemorrhage in relationship to blood pressure lowering. The earlier we can get blood pressure under control, the opportunity to benefit the patients is greater.
Okay. Craig, based on these findings, and do you believe that the early intensive blood pressure lower should now be considered standard of care in all cases? And in which cases would you be more concerned about intensive blood pressure reduction among patients with ICH?
Look, we have not found any serious adverse effects of blood pressure lowering intracerebral hemorrhage. Intracerebral hemorrhage is a different pathophysiological condition to acute ischemic stroke. You have bleeding, a hematoma in otherwise normal brain causing pressure, which is very different to the insidious penumbra activity that occurs in acute ischemic stroke. So if you lower blood pressure and obviously intracerebral blood flow, you are trying to reduce the pressure in that bleeding vessel or vessels, but you're also dropping blood flow elsewhere in the brain. And because there's no ischemic penumbra, there's not an acidious more relationship to collateral blood flow. There is a safety related to that, which is very different to acute ischemic stroke. We can't target blood pressure lowering. In fact, we can't really target medications very well in the brain because medications go through the circulation. So in our analysis, using a standard metric of serious adverse events, we could not show any harms in this analysis. Now, I know there's been a lot of, and I honestly can say a lot of hype related to the ATAC-2 trial related to renal adverse events. Yeah. But you've got to understand an adverse event is a raise in creatinine. And that's very different to weigh up an transient elevation in creatinine to mortality or neurological deterioration. You can't use the same metric of benefits and harms. So I think if you used a hard safety endpoint, which is serious adverse event, we could not show any harms associated with early intensive blood pressure lowering going down to a blood pressure control between 120 and 140 systolic. Obviously, we have to avoid overshoots in blood pressure. And right. we have done in previous analyses a suggestion, it's secondary analysis, but we've suggested if there's a very large precipitous drop in blood pressure, it may be harmful. But for all intensive purposes, if the person is seriously hypertensive with intracerebral hemorrhage, which is at least 3/4 of our patients, we've got to get that blood pressure under control as early as possible and to keep it as smooth as possible for at least the next 24 hours.
All right, Craig. Well, as you know, we are all very proud here in Brazil to be part of to join the INTERACT trials and the effort to reduce blood pressure. But I was wondering, it's very challenging to implement these new changes in strategies and also to implement new evidence in clinical practice. So I was wondering, what are your take-home message, and how can we address this problem of implementation in terms of ICH?
Yes, look, I have to recognize that in clinical practice, there's a lot of barriers. It's all well and good doing the randomized controlled trials in a very controlled and artificial situation, but then extending those results in practice brings about a lot of issues. We take for granted in a high income country setting, we take for granted the ready availability of monitoring devices, ready availability of medication, quick access to intensive care units, highly skilled nursing staff, and that's very different in low and middle income countries. A lot of challenges. So we recognise that. We also recognise the limitation of most intravenous antihypertensive agents. You know, they're not perfect. There's a time delay for efficacy, and there's always the risk of overshoot if you can't perfectly titrate the medication, and if you increase the dose too much, particularly in the context of raised intracranial pressure, then you potentially can get some adverse effects such as bradycardia with the beta blockers. We also worry a little bit about nitrates being used too early with intracranial hemorrhage, maybe exacerbating the hemorrhage. There's some evidence to suggest that. So look, we haven't got all of the answers, but the general philosophy is that any blood pressure agent and ideally intravenously will work, because the whole purpose is to lower the blood pressure. So if you've got nicardipine, hydralazine, metoprolol, urapidil,
Ismolol, we have
clozapine, they're all working much the same. Clozapine is ultra short acting in its half-life. It may be a bit more titratable, but it's a little bit more expensive. None of them are perfect. I think you need to feel comfortable with the drugs that are available with your drug at your hospital, and patiently control the blood pressure over half an hour, 40 minutes. When we first started this journey to assess blood pressure lowering in the INTERACT studies, we were cautious. It was a radical move. Our target was to control blood pressure in an hour. And then when we embarked and we've completed the INTERACT 4 study in the ambulance, it was 30 minutes. I think now that our goal should be to try and get the blood pressure under control within 30, 40 minutes. But if it's very high and you have to sort of do it in a staged manner, as long as you can get the blood pressure under control in an hour, I think it's reasonable. Then we have to think about, well, where are we going to do that? Should it be always in ICU? I don't think so. I think we can do it very readily in the stroke unit, but then that means we have to work with the nurses to feel very comfortable about blood pressure monitoring in terms of managing the patients there on the stroke unit.
All right. Well, Craig, I just want to thank you so much for your availability and also for all the work and the relevance of your work and doing pragmatic implementation research, and that affects a lot our environment in developing countries in special. I really want to thank you for including Brazil and developing countries in the efforts that you conduct and the research. It's a very important research. Thank you so much for your time and for being with us today.
Thank you very much, Otavio. Thank you, everyone.